Good afternoon, everybody. We are going to begin the main conference of this update in cardiovascular disease 2021. To begin with, we will have two topics in hypertension, and to take you through this conference, initially let me hand it over to my colleague, Dr. Soumitra Ray. Soumitra, you start.
Yeah. Thank you, Professor Guho. Now our main scientific academic program is starting after the very exciting case presentation and quiz over last 2 days. We hope that this will create as much excitement as the last two episodes. So we are first riding with hypertension. So we have coined some fancy name for those, whatever those mean. So riding with hypertension, the first we're starting with a debate. In monitoring and management of blood pressure beyond Office BP ABPM is essential. Now, I hand over the session to the chairpersons, Dr. Arup Biswas and Dr. Raja Rai. And in an European and American style, we are not introducing anybody because if anybody wants, he can self-introduce. But as we usually say, we know each other. In this gathering, we know each other. I think all India level, we know each other. So it's better to start straight away.
Good afternoon, respected teachers and my colleagues. My today's topic of debate is in monitoring and management of blood pressure, out of office blood pressure, ABPM is essential. And my senior colleague will speak about no, home blood pressure monitoring is good enough. So despite the advancement of the treatment, the global burden of hypertension remains pretty high. The burden is in 2010, in Global Burden of Disease Study, it is reported it as a leading risk factor, and 9.4 million deaths are every year are there. So based on office blood pressure, the global prevalence of hypertension was estimated to be 1.13 billion in 2015, which is expected to be increased by 15 to 20% by 2025, reaching close to 1.5 billion. The overall prevalence of hypertension in adults is around 30 to 45%, with a prevalence of more than 60% in people aged more than 60 years. Now, what is the role and position of the out-of-office blood pressure measurement like ABPM and HBPM? It is recommended in 2018 guideline, ESH guideline, that out-of-office blood pressure measurement with ABPM and or HBPM is recommended if logistically and economically feasible. So why the office blood pressure is in back foot nowadays? Hypertension guidelines have taken research evidences from clinical trials where office blood pressure was considered and they converted into recommendations, but office blood pressure measured during clinical trials and in reality practice differs, like there is inertia to reach blood pressure goal at the level of patient and also provider. There is lack of time, lack of training and retraining. There is inability to diagnose white coat hypertension and masked hypertension. Both out-of-office blood pressure measurements methods are better in reflecting cardiovascular outcome and LV mass. Few points about ABPM. ABPM provides the average of blood pressure recordings over a defined period like 24 hours. The device is typically programmed to record blood pressure at 15 to 30 minute intervals, and average blood pressure values are usually provided for daytime, nighttime, and 24-hour average. 40 to 60 measurements per day are there. Automated measurements are there. ABPM obtains BP measurements in a variety of conditions. ABPM obtains nocturnal measurements also. Recent advances have also been made to avoid nighttime discomfort of cuff inflation, where sympathetic overactivity might increase night BP. Two salient points of HBPM. HBPM home blood pressure is the average of all BP recording performed with a semi-automatic validated BP monitors for at least 3 days and preferably 6 to 7 consecutive days before each clinic visit, with reading in the morning and the evening taken in a quiet room after 5 minutes of rest with the patient seated with their back and arm supported. 2 measurements should be taken at each measurement sessions performed 1 to 2 minutes apart. And compared with office blood pressure, HBPM provides more reproducible BP data and is more closely related to hypertension-mediated organ damage, particularly LVH. Regarding the definition in these methods, ABPM has 24-hour average definition more than 130/80 blood pressure, daytime average more than 135/85, and nighttime average more than 120/70. And for HBPM, it is more than 135/85. Few important points about home blood pressure monitoring, where 1 to 2 measurements per week or months are required for long-term follow-up. And in ambulatory blood pressure monitoring, at least 20 valid daytime and 7 nighttime BP recordings are needed. If less, the test should be repeated. Now, why the ABPM gained its popularity nowadays? ABPM has predictive superiority. It refines risk stratification in both hypertensive as well as general population. Greater number of reading is there, absence of digit preference and observer bias, better predictor of hypertension mediated organ damage than office blood pressure. Furthermore, it has a more sensitive risk predictor than office blood pressure of severe outcomes such as coronary, morbid or fatal events and stroke, reduction of white coat effect, unmasking of masked hypertension, and measurement of nocturnal BP. Few points regarding white coat hypertension. It refers to untreated condition in which BP is elevated in the office but normal when measured by ABPM, HBPM or both. Prevalence is around 30 to 40%. More common with increasing age, women and non-smokers. And it is not so innocent as having increased long-term risk of CV events reported in recent studies, especially in older patients. Both ABPM and HBPM are recommended to confirm white coat hypertension because the CV risk appears to be lower, close to sustained high normotension in those in whom both ABPM and HBPM are normal. In masked hypertension, it refers to untreated patients in whom BP is normal in the office but elevated when measured by HBPM or ABPM. True normotension means both are normal. Sustained hypertension means both are high. Risk of CV event is substantially greater in masked hypertension compared to normotension and close to or greater than of sustained hypertension, and increased risk of CV and renal events in diabetes, especially when night BP is elevated. So night BP is an important thing. Importance of night BP in SMARC in 1964 first described that importance, that elevation of basal blood pressure following sedation was an accurate marker for adverse health outcome. EDACO database revealed nighttime BP compared to daytime is a better predictor of CV complication. Isolated daytime and isolated nighttime hypertension both predicted adverse CV outcomes, but standardized condition during sleep, supine position and absence of movement probably explains why the nighttime BP is the most accurate prognostic marker. Few more importance, recognized reasons of nocturnal BP dipping are sleep disturbance, OSA, obesity, high salt intake in salt sensitive subjects, orthostatic hypotension, autonomic dysfunction, CKD, diabetic neuropathy, old age, and paradoxically, if there is extreme dipping, there may be increased risk of the patients, but there are limited data to support this point. So there are few advantages of ABPM like nighttime recording, white coat hypertension and masked hypertension identification, and it is a stronger prognostic factor with very few disadvantages like expensive one and can be uncomfortable. Comfort is gained nowadays with recent advances. HBPM, it is cheap and widely available. Measurement can be done in home setting, but with certain advantages like only static BP is available. Potential for measurement error is there. No nocturnal recording. Now there is confusion regarding the competition of ABPM with HBPM. Average HBPM and daytime ABPM appear to have similar normalcy threshold, similar reproducibility, similar diagnostic accuracy for white coat hypertension and masked hypertension, and similar prognostic value, with all these features being superior to office BP. But these two methods are not interchangeable. In Pamela and Ohasama, two population outcome studies concluded that these two methods should be regarded as complementary. Regarding the variability point, ABPM provides short-term variability, HBPM day-to-day variability, Office BP provides long-term variability, but the relevance of this variability metric in predicting CV outcome is still inconclusive. Issue of reproducibility, Guo et al. Found that morning BP, irrespective of the assessment methods and definition, was generally reproducible and significantly associated with vascular indices. Morning blood pressure might be preferred in this case. As there is no proper study for this issue regarding ABPM, we cannot conclude from the available documents till date. Now, regarding the hypertension mediated organ damage, Bridgiotis et al. Compared HBPM and ABPM and Office BP using meta-analysis to predict the outcome of HMOD, and it included LV mass index, urinary albumin excretion rate, EGFR, carotid artery IMT, and pulse wave velocity. HBPM became comparable to ABPM as a correlate to LVMI. Both were better than Office BP. But after this discussion also, can HBPM replace the ABPM? This is the main topic of discussion today. Now, home blood pressure monitoring does not allow easy recording of night blood pressure. Isolated nocturnal hypertension, which confers equal risk of daytime hypertension, can only be diagnosed straightforward by ABPM till date. ABPM is better for diagnosing hypotension, particularly in elderly, where postprandial and postural hypotension are common due to impaired ANS and attenuated baroreceptor reflex. Carotid atherosclerosis was associated with Hbpm in Japanese, but in the same cohort, ABPM was a stronger predictor of cerebrovascular disease. Hbpm misses the high-risk diagnosis of MH and sustained hypertension in over 25% of patients in few trials also. So, a big no of the question, answer is the big no of the question that can Hbpm replace ABPM. Few points regarding role of ABPM as a treatment guide. Though ESC gave considerable attention in diagnostic role, but relatively less words in treatment role in initiating and following the efficacy of treatment. Concluding message from Spanish study, they compared casual BP measurement with ABPM, and there is led to reduction of proportion of older subject recommended for hypertension treatment and a substantial increase in the proportion of those whose hypertension was controlled. Follow-up with ABPM in case of hypertension-mediated organ damage like diabetes, it seems reasonable to repeat ABPM at 3 to 6 weeks to determine adequate BP reduction. Also, excessive lowering of BP, particularly night blood pressure, can be avoided, and once controlled, 6 monthly or annual ABPM is prudent. Now, regarding the cost effectiveness of ABPM, those who are in favor of Hbpm due to its cost of ABPM, initially it was thought to reduce the cost of antihypertensive treatment in white coat hypertension with ABPM use, but nowadays the benefit extended in reducing cost of managing complications also. Krakow analyzed the potential saving of 3 to 14% for cost of care of hypertension and 10 to 23% reduction in treatment days when ABPM is incorporated. In 2011, Lobibond et al. Suggested that ABPM was the most cost-effective strategy for diagnosing hypertension in women and men of all ages and resulted in more quality of life adjusted life years for women and for men older than 50 years. Now, last but not the least, what world says in Chinese 2019 ESH-ESC 2018 and Australian guideline, both modalities are preferred, home BP and ABPM. But in NICE guideline 2019 and ACCIHA guideline 2017, ABPM is preferred, and in Canadian guideline, actually both are preferred. So from this discussion, we can say that still now ABPM is quintessential for monitoring and management of the blood pressure when office blood pressure is concerned. Thank you for your patient hearing.
Somnath, for nice presentation.